introductions of our speaker to Martha Butterfield, the Program Coordinator of NJCTS. Marty?
Thanks, Kelly. I would like to welcome everyone to the presentation portion of tonight's webinar.
Me neither.
One moment, we have a little technical difficulty. We will get Marty back on the line in a moment. All right.
Hi, can you hear me now?
All right. I will do the introduction of Dr. Rockmore. I'd like to welcome everyone to the presentation portion of tonight's webinar. Our presenter is Dr. Lori Rockmore, who will discuss psychological services, how psychological services can benefit individuals with TS and what treatment options are available. Dr. Rockmore received her Doctor of Psychology degree in Social Clinical Psychology from Pace University and did her postdoctoral training in child and adolescent trauma at Mount Sinai School of Medicine. Dr. Rockmore's expertise is in child development, impulse control disorders, parent training, and social and emotional learning. She works extensively with parents and children and consults with school districts from preschool through high school. Dr. Rockmore is the director of the TS Practicum, a partnership between the New Jersey Center for Tourette Syndrome and the Graduate School of Applied and Professional Psychology at Rutgers University. I would also like to point out that Dr. Rockmore does not have a medical degree, therefore she will be unable to answer any specific questions related to medications, medication side effects, or the medical management of Tourette syndrome. I will turn this program over to Dr. Rockmore to begin.
Thank you, Kelly. Sorry we didn't get to hear from Marty. Let's see. Oh, see if I can get this to come up. Okay, it's the presentation. Oh, I got it. Sorry. Technology thing.
That's okay. We'll bear with you.
Thank you. I appreciate it. You show. All right, here we go. Okay, well, I do want to thank everybody for the introductions. And again, my name is Dr. Lori Rockmore, and it's a pleasure to be here tonight to talk to you about the mental health treatment options available to individuals with TS. I have been a part of the partnership, like Kelly had said, between the NJCTS and Rutgers University's Graduate School of Applied and Professional Psychology, or us Rutgers people call it GAZAP. And I've been a part of this partnership for the last 4 years, and I've been serving as the clinical director of the TS program here. Our program is a popular training site amongst the doctoral psychology students at Rutgers, where we train them to understand and treat TS and its comorbid disorders. I have 4 students each year that I train, and I'm really excited for one day when they're able to actually get out into the community and begin to deliver services and train other clinicians in the treatment approaches that we'll be discussing here tonight. Okay, so, and also I should say that I am a parent, and I am missing my son's back-to-school night tonight, so I'm sure I'll be hearing about that for quite some time to come. Let's do this. All right. Okay, so the treatments that we're going to be discussing tonight. We're going to be talking about exposure and response prevention, or ERP for short, for obsessive-compulsive disorder. We're going to be talking about cognitive behavioral therapy, or CBT, for anxiety disorders. We're also going to be touching upon CBT for depression. Also talking about psychosocial interventions for disruptive behavior disorders. And also a pretty hot topic, the comprehensive behavioral interventions for tics, or otherwise known as habit reversal. We'll be talking about all these different treatments because all these different disorders that are related to the treatments are disorders that have been shown to be in the TS population with higher prevalence. So the first thing we're going to be talking about is OCD and the treatment for that. Differentiating OCD from tic symptoms can be difficult given the significant rate of overlap between OCD and tics. Reports indicate in the literature that 20 to 60% of individuals with TS will also have comorbid OCD. Simple tics are not often mistaken for OCD due to their short and purposeless nature. However, the complex tics, such as touching, tapping, or rubbing, to achieve a just right phenomena or just right feeling can sometimes be a very difficult thing to distinguish from compulsions, and also can be found on inventories that look at both disorders, both tics, TS, and OCD. The typical rule of thumb to distinguish tics from compulsions is that tics have a sensory urge, while compulsions have a mental urge. In that, typically someone with OCD engages in hand washing because of the fear of germs. And typically someone with tics engages in their tics because of a sensory urge or what we call a premonitory urge to perform that tic. Okay, so I'm going to talk a little bit about exposure and response prevention and what it actually is and how it treats OCD. Exposure and response prevention has been shown to be the treatment of choice for OCD, and the effects of the treatment actually have been shown to be more long-lasting than medication effects in and of themselves. Exposure and response prevention has been shown to be effective for OCD across the age span, so from kids as young as, we've seen it work in kids as young as 6 to adults. And it's considered to be the psychological technique of choice for OCD, like I had said previously. Effects of ERP for OCD have been shown to have lasting effects, like I said, even after treatment is finished, unlike that of medication. Typically, once medications are discontinued or no longer used, OCD symptoms do return. However, with ERP, we typically don't see that. It is a management strategy that people need to keep practicing, but it does have long-lasting effects if the individual keeps practicing it. So ERP involves repeated confrontations with situations that provoke distress while encouraging the individual to abstain from any anxiety-reducing rituals. I'll explain that a little bit more. In that, so the individual who has to wash their hands for fear of germs is exposed to that fear of the germs and is prevented from washing their hands. Or something that we see very commonly here in our clinic is that we have children who repeatedly need to ask their parents the same question over and over again. Sometimes they don't know exactly why they have to do that, but other times they express fears that they won't remember what the parent said exactly. And in that case, what we instruct the parent and child to do is not allow the child to actually ask that question again sometimes. If they can't do that, then we instruct the parent to not answer the question more than once and to be able to sustain the child's discomfort with not having that question answered again. So by not giving in to the urge to engage in a ritualized behavior, the urge gradually decreases through a process, a technical term, called habituation. However, if you actually sit with that, the behavior eventually decreases or extinguishes. Okay, we're going to move on to anxiety disorders. And again, TS has been shown to be associated with increased rates of anxiety with a significantly higher lifetime prevalence, or just we see it more often in individuals with TS, for such disorders as generalized anxiety disorder, which we actually see in 44%, it's been reported to occur in 44% of TS patients. We also see an increased rate of panic attacks and other phobias as well. So this increase in anxiety in the TS population is thought to be in relation to the possibility of tics being embarrassing in social situations, which can cause substantial anxiety. Additionally, the factors of stress, anxiety, and positive excitement being found to be exacerbating effects, or they make them worse, could be another factor contributing to an increased rate of anxiety in those with TS. So how do we go about treating it? CBT has been shown to be effective for treating anxiety disorders such as generalized anxiety, panic disorder, and social phobia. And CBT for anxiety disorders focuses on confronting both fears and avoidance strategies that help maintain the fears. Similar to CBT strategies for the treatment of OCD, During exposure exercises, patients learn to expose themselves to anxiety-provoking situations, and then they refrain from any avoidance behaviors, just like we talked about in OCD, just the slide before. So in this way, patients learn two things. One is that anxiety eventually does decrease by itself. And two, that the anticipated negative consequences actually do not occur. So depending on the nature of the individual fear, the individual may be exposed to social situations such as we see in social phobia, everyday kinds of worries we would expose them to if they were suffering with a generalized anxiety disorder, or we would expose them to somatic sensations such as would be experienced in individuals who have panic disorder. So in addition to the exposure to feared situations that we talked about in the previous slide, another aspect of anxiety disorders that we educate patients on is the, I missed the psychoeducation piece. So we talk about the psychoeducation about the nature of specific anxiety disorders and the vicious cycle of how avoidance maintains the individual's fears. So exposure, again. We educate them about exposure, but we also start to educate them about the physiological arousal that is typically felt in individuals suffering with anxiety disorders. Of course, we have to receive medical clearance from the individual's physician to make sure that there actually is nothing going on with them, like a heart condition or anything like that, before we say that the physiological arousal is due to the anxiety. So individuals with anxiety disorders need to understand that the physiological sensations of increased heart rate, sweating, butterflies in the tummy that most kids talk about, and or tensions in one's muscles are not signs that there's something seriously wrong with them, but indicators that they are indeed actually anxious. So the two ways that individuals can identify if they are anxious is by looking for signs of physiological arousal and or if their thoughts are anxious in nature and that they're expecting something bad to happen. So what do we do with those thoughts if they have the thoughts that something bad is going to happen? We first identify them, and then what we do is we employ a technique called cognitive restructuring. Cognitive restructuring focuses on identifying and then modifying cognitive errors, such as, like I have up here, of overestimation and catastrophizing. So an example, just to make it a little bit more clear about what these two distortions of thinking are in anxiety disorders, overestimation of Tourette would be the individual who believes that something bad is likely to happen if they do or do not do something. So if they do not wear this green sweater today, then they're going to get into a car accident. That would be something that's overestimating the threat. And then an example of catastrophizing would be an individual who believes that if they have a little bit of a shake in their voice or if they have a little bit of a nervous appearance during a presentation, that their audience will think that they're incompetent and not capable to be talking about the subject that they're talking about. It's a very common one for people with social phobia or who have fears of actually speaking in public. So the clinician's job is to identify these distorted cognitions and then to work with the individual to question the accuracy of the cognitions. In this way, the patient learns to reevaluate their thoughts and their negative interpretations related to their fears. Okay, moving on to depression. So again, we have elevated rates of depression that have been found in children and adults and adolescents with TS. And there are several hypotheses as to why this may be the cause. It may not be the actual reason. Hypotheses are estimated guesses or guesses as to why this may be the case. Why is it that depression has been found more prevalent or occurs more often in the TS population? So one of the hypotheses is that the burden of disruptive or debilitating tics may be related to the development of such symptoms, such as low self-esteem and hopelessness. And another guess is that the individual with TS may perceive criticism from family members or coworkers or peers with respect to failing to suppress their tics. And they believe that maybe other people think that they're actually ticking on purpose. So those are the two reasons that are floating around out there that it's a possibility as to why we see more depression in the TS population. Okay, so what do we do about it? In the world of CBT, we have a guy that we actually coined, Aaron Beck, and his colleagues, and back in 1979 really came up with the foundations for treatment for depression. especially from the CBT or cognitive behavioral therapy approach. So since 1979, the efficacy or the effectiveness of CBT for depression has been shown to be an effective treatment for both adults and children. Again, we have studies to support its use in both populations. And, excuse me, I just got to turn my phone off. So as can be seen by this slide, CBT for depression actually has a similar format to the one I just discussed for anxiety disorders. Click that off. I apologize. Okay. So treatment usually begins again with the psychoeducation about the nature of depressive disorders and how negative cognitions and patterns of inaction actually influence mood. In this model, depression is believed to be maintained through unrealistic negative thinking and inaction, and again, withdrawal from one's life. So basically what we see is we see these negative thoughts, plus we see people withdrawing from their normal life activities and not doing what they typically would be doing in their lives. So the process of cognitive restructuring consists of becoming aware of these automatic negative thoughts and interpretations, and then treating these thoughts as hypotheses or educated guesses, and not as actual facts. These hypotheses, I'm sorry to keep using this word, but these educated guesses are then evaluated in terms of the evidence that one is able to elicit to support or disprove them. So basically what we're doing in cognitive restructuring is we're looking at the individual's negative thoughts about a situation, and then we're coming up with other possibilities that could explain the same thing. And then we're looking at them as looking at all the options involved. It's not always the first thing we think of. It has a lot of other possible explanations. So we then look at problem solving and coping skills, which are usually added to CBT for depression when we're working with children. And we're doing this in order to help them learn skills that they can use to achieve and or maintain a pleasant mood. And then finally, which I think is actually the most important piece of the depression, CBT for depression, is emphasizing the importance of scheduling positive and pleasant activities. In addition to re-engaging in activities that individuals have actually withdrawn from and used to enjoy. So sometimes we have kids who stop attending soccer, they don't want to go to their soccer practice anymore, or they don't want to have play dates anymore with their friends, or we have adolescents who are not going or not calling their friends anymore. They stop picking up the phone. All these things we want to try to re-employ in these children's or these adolescents or adults' lives, because really what happens is the longer you stay out of these activities that you used to enjoy, the more depressed you actually become. So I do think that the scheduling of positive and pleasant activities and re-engaging in activities that you used to enjoy are very important parts of treatment for depression. Okay, let's go on to disruptive behavior disorders. So again, the literature tells us that 37% of TS patients report a history of anger control problems. Okay, however, aggressive behaviors are believed to decrease with age. So basically what we know is that we may see an increase of aggressive behaviors in children, but as they get older, as they go into adolescence and as they go into young adulthood, we typically see a decrease in these aggressive behaviors, which is good news for us. And that is without any treatment at all. Disruptive behaviors in TS take various forms and most frequently include what I have listed here: explosive anger, physical aggression, and noncompliance. So I'd like to just take a few minutes to just explain what the difference is between these three terms, because often they are confused. Anger is the negative affective state or emotion. So it's something that we all feel. It's one of the basic emotions, and it's reported to occur regularly in the population. We all feel angry. It's normal to feel angry. Anger can vary in intensity from mild annoyance to rage. Rage is not so typical. And anger expression can be characterized in terms of physical and verbal aggression. So the aggression is the actual act. Physical aggression is the actual act that we put out into the world. So studies with healthy individuals show that talking and problem solving are actually the most common behaviors associated with anger. And in turn, they are also the most productive. So in contrast to anger, like I said, which is more of an internal feeling, aggression is more of an external expression. So aggression refers to behaviors that result in harm to oneself or others. And then to explain noncompliance, which is what we do see a lot of here in our program with children that come in, noncompliant behavior is defined as a refusal to follow instructions or established rules. Okay, so I'm going to talk for a few minutes about the treatment approaches to disruptive behavior that we use here and also are talked about very frequently in the literature. So parent management training is a psychosocial intervention in which parents are taught methods of reducing a child's disruptive behavior and also fostering pro-social behaviors by using positive and negative reinforcement kinds of strategies. Both Russell Barkley and Alan Kazin have manuals that outline this treatment approach and books that do the same. So within this approach, aggression is viewed as being reinforced through the mechanisms of escape and avoidance in which they are thought to engage in aggressive behavior to avoid certain family interactions. So let me explain that a little bit more. So an example of it would be when parents withdraw limit setting in response to a child's temper tantrum. The tantrum is being reinforced by the removal of the unpleasant parental discipline. Parent management training gives clear guidance for training parents on how to break this cycle. Now, I'm sure all the parents out there, myself included, are saying, well, of course this happens in my household. There are times when we all give in to our child's demands for the sake of our sanity, and that's fine. I mean, we all do it occasionally. However, it only becomes problematic and could be a factor related to a child's disruptive behavior, anger, or aggression when you're giving into your child's tantrums more than not. So if that is the case, then maybe parent management training is the right treatment of choice for you. So let's talk about the core skills involved that we teach parents is that we teach about positive reinforcement for appropriate behaviors, communicating directions effectively, and being consistent with consequences for disruptive behaviors. We also use and employ techniques such as the token economy and timeout, which we also use within this approach. So the take-home message about parent management training, which is different than the other two treatments, is that parent management training is specifically working with the parent, where anger control training is a little different. It's working specifically with the angry or aggressive individual. It involves helping the individual develop emotion regulation skills and social problem-solving skills for coping with conflicts and frustration. So again, this approach is most appropriate for the individual who gets angry when they think that they have been deliberately treated unfairly. Those thoughts may be triggered not by the actual actions of another person, but again by these distorted thinking or this distorted understanding of the other individual's intent. It's believed that it's this distortion that can lead to increased feelings of anger and aggression. And then in anger control training, the core skills that are taught in this approach include arousal management, so managing your physiological arousal when you feel angry, cognitive restructuring, again, that very popular term that we use in the CBT, and also behavioral practice, practicing how to manage anger appropriately. So a lot of role-playing, coming in with situations that occur that make them angry or aggressive, and then role-playing them out in a more productive way within the therapeutic setting. Okay, so again, I said parent management training is working with the parents. Anger control training is working more with the angry individual. And collaborative problem solving is a treatment approach that works with parents and children together as a family. This approach comes from the work of Ross Greene, who is the author of the very popular book, The Explosive Child and Treating the Explosive Child. He has 2 books out. Dr. Greene, he postulates or believes that aggression is a byproduct of an incompatibility between the characteristics of a given child and their environment. So the child is actually thought to be lacking certain skills, such as flexibility and frustration tolerance, which are believed to be necessary to help manage anger and aggression. These skills are taught through the process of collaborative problem solving, which is, again, the term that he uses for his approach. And parents are taught to put situations into 3 different baskets. You have basket A, which is situations or issues that are of life or death importance. And the parent is then willing to ensue an aggressive episode for this demand to be put upon their child. And then basket C, we're skipping over basket B for a second, is being situations that you're willing to drop expectations of for the time being, just for now. And then basket B are the situations for which you're actually actively problem solving with the child. So situations move from back and forth between basket C and basket B. The collaborative problem-solving model implies that the skills involved with problematic anger and aggression that are lacking in children with explosive anger can be taught through this process of collaboratively problem-solving specific situations that have been problematic in the past and then will come up again in the future at some point. It's a very proactive approach with an emphasis on the antecedents or triggers to a given child's aggressive episode. So just to know that choosing which of these three methods to use for treating disruptive behavior really should be left to a mental health clinician and should be based upon a thorough understanding of a given patient's specific and unique clinical presentation. So each approach would really be geared for a different type of child or adult or adolescent. Okay, moving on to a hot topic here, comprehensive behavioral interventions for tics, CBIT for short, or habit reversal therapy. Okay, so they're terms that actually are used interchangeably, but they're generally one and the same treatment approach, with habit reversal being the basis for CBIT. Okay, so however, I'm going to use the term habit reversal just for the sake of simplicity throughout the rest of the talk that I'll be giving tonight. So when I began working with individuals with TS about 10 years ago, I would have never thought that tics could be treated successfully without medication. Habit reversal was kind of a fluke, and I didn't think much of it at that time. So I was aware of small research studies looking at this treatment, and I was highly skeptical. And I was skeptical until about 2 years ago when I was first introduced to Dr. Doug Woods, and he's from the University of Wisconsin at Milwaukee. I met Dr. Woods, and I had him come and deliver a full-day training here at Rutgers for myself and my students. And I really started to see the value of how habit reversal could play, how valuable it could be in the lives of individuals with TS. Habit reversal, really, I saw it, and what Dr. Doug Woods was talking about was that it's a management strategy, and it's just there are strategies that you use just like exercises for your tics. So I thought that was an interesting concept, and I decided to learn a little bit more. So habit reversal is the most extensively researched behavioral treatment for tics to yield significant reductions in tics immediately and also at 1-year follow-up. The success of habit reversal decreases when an individual who presents for treatment has one or more of the following characteristics: has poor response inhibition, ADHD, children who are below 8 years of age, individuals who have severe cognitive impairment, a chaotic family environment because it really is a family approach, a family treatment. Children do need support of their family in order to engage in this treatment. And also individuals who have poor motivation to decrease their tics. We haven't found much success with habit reversal using those with this population, except when we're able to increase their motivation. So what is habit reversal? Good question, right? Habit reversal has three main components, and they were first introduced by these two guys called with their last names of Azrin and Nunn in 1973. And the underlying principle, as I believe it as to why habit reversal works, is that the expression of a tic occurs in order to alleviate the discomfort associated with the premonitory urge experienced prior to the tic occurring. So it's therefore believed that according to this principle, that the tic is therefore maintained and perhaps progresses or gets worse due to what we call a negative reinforcement cycle, big term, and I'll explain it, meaning that the reason why we tic is because the tic gets rid of that really annoying premonitory urge. And that's the basis for why habit reversal works. So the tic is performed to get rid of that premonitory urge. Okay, so the three main components of habit reversal therapy are awareness training, competitive response training, and social support training. I'm going to talk about each one of these in a little bit more detail. The main purpose of awareness training is to help the patient identify and then discriminate the specific tic that is being targeted for treatment. So we only work on one tic at a time. So we're only doing awareness training for one tic initially. In order to do this, we help the patient first describe the tic in great detail, starting with the first urge they actually feel, the beginning of the actual movement of the tick, and then take us through the tick in a very sequential manner. Once they're able to describe the tick in really great detail, we then move on to helping them detect their tick with the greatest amount of accuracy, to the point where they're able to identify the urge to tick prior to the tick actually occurring. And we do this through simple hand raising whenever they feel that tick coming up. Once the patient is able to identify the urge to tick with great frequency, we move on to the competitive response training. During competitive response training, the patient is taught to engage in a physically incompatible behavior when they have the urge to tick. So let me give you an example. Someone who has a throat-clearing tick would be instructed to engage in what we call deep controlled breathing for 1 minute or until the urge to tick actually subsides. So it's incompatible. We can't have a throat-clearing tick. We can't actually make that gesture with our throat at the same time where we are breathing deeply. The competitive response is then practiced in the therapist's office, and then the patient is sent home to continue practicing the competitive response on a daily basis. The urge to tick eventually subsides, and the competitive response then becomes no longer necessary. And the third component of habit reversal is the social support training, where we instruct the patient's family members on how to reinforce and prompt the use of the competing response. It's really important to stress to the family members that we're praising the patient's use of the competing response, and we're not praising the decrease in ticks. The decrease in ticks will come if they keep praising their use of the competitive response. So we want the individual to be practicing as much as possible. Okay, so habit reversal has actually been studied for over 30 years using really small sample sizes and group experimental designs, which is just part of our research jargon. It's considered an effective treatment for tics according to the American Psychological Association, and to date we have 6 randomized control trials, which are the gold standards in research, which have been conducted with really promising results for the effectiveness of habit reversal. Sample sizes have ranged from 10 individuals to 42 within these studies, and it's been shown to be equally effective for adults and children. Thus far, that is. There are always more studies coming out. However, there is some evidence to suggest that habit reversal and exposure and response prevention, which is generally used, like we talked about earlier, to treat OCD, may have similar results. So it's a possibility that the treatment that we use for OCD may actually also work just as well as habit reversal for tics. But again, there's more research being done about that. I just wanted to throw that out. So despite all the support for using habit reversal with individuals who have tics, there are many beliefs about the treatment that inhibit people from actually trying it. The first belief being the idea that individuals who suppress their tics experience what we call rebound effects, which means that if they actually suppress a tic, it makes them tic more at a later time. And secondly, the idea of symptom substitution, in which the belief of stopping one tic makes others worse or replaced by new ones, is another inhibiting belief. And then thirdly, we have focusing on stopping tics causes you to miss important information in your environment. There has been recent research that has demonstrated that these concepts actually do not hold up to scientific scrutiny. So they do not hold up in the lab or in research settings. And they actually, from that we may imply that it's a possibility that they're not actually true phenomena, but just individual experiences that individuals with tics have. So I'd like to just talk a little bit about a case that I had. One of the first patients that I had that I tried habit reversal on was a 22-year-old man who was complaining of what we called a whoop grunt tic. He had this high-pitched whoop that was followed by a deep guttural grunt, which was disturbing to him and his coworkers and his friends. And he was becoming socially isolated because he was fearing that he was being stared at and strangers were making comments to him, and he just didn't want to deal with it any longer. So he started withdrawing socially, and he came to me asking and begging and pleading for habit reversal because he had read about it. And so once he learned the habit reversal strategies, he really was very motivated to do the treatment, and he began to implement them. And the tic actually diminished to a nearly undetectable level within the first week of him practicing the competitive response training. So when he reported that it took him about 5 days of practicing to get that tic to a nearly undetectable level. I have to say that before this case, I was skeptical But following working with this young man, I really began to believe that it is possible that habit reversal does actually work for some people, and that it should be a role in the treatments that we offer to individuals with tics here at Rutgers. So let's get back to the primary question that brought us all here tonight. Can mental health treatment be helpful for individuals with TS? And the answer is definitely yes. Okay, so due to the fact that individuals with TS have higher prevalence rates of OCD, non-OCD related anxiety disorders, depression, and disruptive behavior disorders, what we all talked about tonight, they have empirically supported psychological treatments for these disorders. And if we have empirically supported, research-supported treatments, and we know that they work, they can also be helpful for the TS population, and they should definitely be used and tried. Habit reversal has been shown to be an efficacious or effective behavioral treatment for tics. However, there are, of course, some limiting factors, such as poor, people who have poor response inhibition, ADHD, children who are under 8 years of age, individuals who have severe cognitive impairment, a chaotic family environment, and poor motivation to decrease tics. All those factors decrease the effectiveness of habit reversal. Habit reversal therapy is a treatment option for individuals with TS. However, the promise of treatment success is lowered, like I said, if the patient has one or more of the factors that we just talked about. CBT in general, which encapsulates all the treatments that I discussed here tonight, should be an option for most individuals with TS who are in need of mental health treatment. CBT is a very different type of treatment from a traditional psychotherapy, where in CBT we do not believe that the patient should be in treatment for extended periods of time. Instead, it's the CBT therapist's goal to teach the patient and the family members that we teach them strategies to manage their symptoms. And eventually, it's our goal to turn over the treatment to the patients and their families themselves. CBT is not a cure for psychological problems. However, CBT does aim to give patients what we call a toolbox to be able to choose from when they're faced with the specific difficulties that are associated with their specific conditions. And just a little take-home message to the clinicians who are out there that are listening, and also the families who are receiving treatment from mental health practitioners in the community, that clinicians in the community need to take what they know about these disorders and their treatments and then apply them to individuals with TS. It may be helpful to consult with a clinician who's knowledgeable with TS because there are certain nuances that we see within TS individuals, but it's not to say that they shouldn't go ahead and to try to use these approaches with their patients. There are people who are knowledgeable in TS, and your local chapter of the TSA can also be of some help in finding experts who you can consult with regarding clinical matters. And on that note, I am going to turn back the questions over to Kelly. And I want to thank you for listening and being a part of the presentation tonight. And I'm open to taking questions. Kelly, would you like me to start with the questions that were sent in before the presentation?
That would be fine, and we do have Marty online as well, so she'll be asking the questions.
Okay, perfect.
But you
Welcome,
can start
Marty.
with yours that you have on your slides.
Okay, I'll start with those. So questions that were sent in earlier, can TS be managed effectively without medication? I think that this talk really spoke very highly to the fact that we do have psychological treatments or mental health treatments that can effectively manage TS. We have treatments that could help with tics, such as habit reversal or CBT. We have we have proven treatments to treat OCD and work with OCD related symptoms. We have strategies to work with other anxiety disorders and depressive issues. And we also have strategies that help us with individuals who are presenting with disruptive behavior disorders. So yes, there are definitely treatments out there that can help individuals with TS that don't necessarily include medication. The second question that was sent in, what impact does diet have on a child with Tourette, and does homeopathy work or help? It's a very good question. It's a question that comes up a lot here at Rutgers at our program. And the truth of the matter is that we don't have any research to support adding things or taking things out of one's diet has a direct impact on Tourette's. With that being said, we don't have research, so I can't actually recommend anything. However, certain people have certain things that they remove from their diet and they do see success with. They do see a decrease in tics. But again, I think it's on a very individual basis, and you need to be able to figure it out for your own child or your own self. And just to make sure that you're not removing so many things from an individual's diet that they are, raging for that reason, or they are, they're depressed because they can no longer have certain things in their diet. So you need to weigh the costs and benefits of removing things or adding things to a child's diet. Okay, question number 3. How can we help adolescents whose TS symptoms subside that are then replaced with OCD symptoms? Okay, this is a tricky question because sometimes what could look like OCD symptoms are actually complex tics. So we need to really look very carefully and evaluate very carefully what is what here. So what I would do is if it is truly OCD, then what you do is you would employ exposure and response prevention strategies for working with these symptoms. But again, a very good assessment is needed first. Okay, the 4th question. My 15-year-old has been in counseling for 4 years. He has severe depression, insists therapy is not helping, and wants to stop. I fear his mood will worsen and will likely lead to an emotional nosedive. If therapy and medication is the best we've got, what do we do? Okay. It's always disheartening when we're in therapy for such a long period of time and we feel that it's not helping or it's it's just not working. And I don't know if if they ever felt like it was working, but 4 years in therapy is an awful long time, in my opinion. And with some other treatment approaches, it's totally typical. So what you may want to do is you may want to see if your adolescent, actually your 15-year-old, would be willing to see a different therapist, go for a consultation with somebody of maybe a different orientation, maybe a CBT therapist, maybe a supportive therapist. I mean, just finding somebody that's different. If he has severe depression, you have to be careful of his mood worsening. So what I would try to do is I would try to find another therapist, maybe of a different orientation, maybe of a CBT therapist, someone who's going to do CBT for depression. And also maybe finding what we have a lot of success with here at our clinic is that adolescents typically like working with therapists who are a little bit younger. So maybe we have a lot of success with our adolescents, with our graduate students here. They just feel understood. They feel like the graduate student or the younger clinician, it could be a clinician that was just recently licensed or, somebody who just is a little bit younger. They may, and I don't know, maybe the current therapist is somebody of that, that qualification. But sometimes just adolescents click better with younger therapists. That's been our experience here. So hopefully that works out for you, and good luck with that one. The 5th question. My daughter diagnosed severe TS, anxiety, and panic attacks. We're seeing a psychologist about 12 times when Horizon told us that we used all of our allowed visits. Biological disorders equals unlimited visits, not TS. Can you recommend a way around this? What I would look into is the diagnosis code that was used on the bill that was submitted, or the reevaluation for the additional sessions. So sometimes, the diagnosis code, you need to look at that to make sure that they listed TS as the primary diagnosis and not any of the other disorders that are going on. TS is generally seen as a biological disorder. So, but again, every insurance company does have different policies. So I would try to go back and see what the diagnosis code that was used, try to make it have TS show up there, and then also you could always do an appeal. You could always have your therapist do an appeal with your insurance company and state as to why additional sessions are actually needed. So both yourself as the parent and the clinician involved can make an appeal to the insurance company, and sometimes being just being persistent about it pays off. So another hard issue, but I would definitely not give up on it. And I think that's the end of the questions that I had submitted to me prior to the presentation.
All right, I'm going to start. I hope everybody can hear me this time.
I hear you.
That's good. I have a question from a speech pathologist, and they want to know if, besides stuttering, what other problems of speech language can develop.
Okay. That's a good question. Other problems of speech that we see echolalia. So we see people repeating other people's words. We see palallalia, which also could be people repeating their own words. We see people needing to add words before, like adding an before their sentences. We see people just trying to pull from my own experiences of speech atypicalities that we've seen. Again, I'm not a speech pathologist, but those are primarily the different speech kind of patterns that we see. So the stuttering, the echolalia, the palallalia, adding like an before a sentence. Sometimes there's some words that they say after a sentence, so a tick could follow a sentence. That's all that's really come up in my experience.
Okay. My son has an urge to stick his finger down his throat to touch the back of his throat. Is this a tick? He often vomits because of it, and it's become a real problem.
That's a hard one. I mean, it could be a tick or it could be a compulsive behavior, depending on where that urge is coming from. So what I'd like to know, if it is, if he has just this urge to stick his hands down his, his finger down his throat, then that would be more tick-like. But if he's doing that to relieve any kind of contamination, or he has a fear about, about something being in his stomach that's contaminated, which I've seen both cases. So we need to figure out what it is, and it definitely could be a complex tick. So, and that's something that, if he's motivated, habit reversal could work very nicely for, if he has, if he meets the criteria for habit reversal.
Okay. If ADHD can limit the impact of habit reversal, what about a bipolar diagnosis?
We don't have any research saying as to whether bipolar is a rule-out criteria or it impacts it negatively. It would depend on what phase of bipolar they're actually in. So whether they're in a depressed state or a manic state, I think it's really on an individual basis. So I don't think we could rule out, anyone with bipolar disorder. However, it would really need to be evaluated on an individual basis.
Okay. I have a question about hypnosis. Is hypnosis effective or recommended for habit reversal?
For habit reversal?
Is hypnosis effective or recommended for habit reversal?
I'm not sure if I understand that question as to how habit reversal, hypnosis doesn't play a role in habit reversal. So I'm wondering if they're talking about hypnosis being a treatment for TS. So I'm not really sure of how to answer that question.
Okay. What is the difference between CBT and EMDR therapies? And I don't know what EMDR therapies
It's
are.
eye movement, EM desensitization, EMDR, and reprocessing therapy. So EMDR is a type of CBT that additionally has an eye movement component. So basically, what you're doing is you're training people to follow like a wand or a finger, and it has something to do with the processing of visual images. I know a little bit about it only because it's written about in the trauma literature, which I have a background in, but I've never actually practiced EMDR. And there's a lot of research out there to say that the actual eye movement, when you compare EMDR to CBT, there is really no difference. The eye movements don't make a difference in the treatment. So basically, EMDR is CBT in itself with the added component of the eye movement processing. But again, research has not helped there are many proponents for EMDR, and there's a lot of people who think that it's a really great treatment. Again, I don't have much experience using it, but what the research tells us is that there really is no difference between straight CBT and EMDR with the added eye movement.
Okay, thank you.
You're welcome.
Can you explain the difference between OCD and complex tics, and why is it significant?
Okay. So the difference between OCD and complex tics. So not OCD in general, but the compulsions could resemble complex tics. So a compulsion to, one that gets tricky and gets in our way sometimes is the compulsive need to tap a certain amount of time. So if I don't tap my desk 4 times on my right side and then 4 times on my left side, then something bad is going to happen. And in order to treat that compulsion, you need to actually expose the person to the feelings of something bad going to happen and not allow them to engage in that ritual. So that's the way that we would treat it. And a complex tic with the same tapping would be an individual just tapping because they feel the need to tap, and there's no negative consequence that's going to follow from that. It's just a sensory urge that they have to actually tap. So you may not know that the individual is tapping 4 times, but you need to really ask them about that and really interview them very carefully about that because it has treatment implications. And whether you're going to use exposure and response prevention or you're going to use a habit reversal therapy. And that's the primary reason why we want to know the difference. Is it a sensory urge or is there a mental component to it like in a compulsion? Does that answer the question, hopefully?
I hope so. My son has a compulsion to draw. I'm not sure if it's a tic or OCD, but once he begins, he has a difficult time stopping himself. Any suggestions on what could help him with this?
Okay. Again, it's hard. These questions are really great questions, and they're hard to do in this forum. I like to see the compulsion. I like to interview the child about it. Are they compulsed to draw because if they don't draw, something's going to happen, bad's going to happen? Are they drawing because they just have the urge to draw? Like, all those things need to be really fleshed out. And what you want to try to do, generally, when you're dealing with compulsive behaviors or these behaviors that are just excessive in nature, is you want to try to come up with creative strategies to get them to stop. So get them to delay doing the drawing for a little bit of time, trying to distract them in a little bit of way, just for a second initially, and then making it larger and larger time intervals. Anything you can do to interfere with the process is actually a good thing. It can be tough on the child or the individual because this urge is building up in them, or this feeling of something bad is going to happen is building up in them, and that becomes very uncomfortable. So, but the way that we really are instructed or taught to get kids out of these kinds of all-encompassing kinds of behaviors, such as this individual is talking about, is to really do anything we can to get them to divert or distract or to stop the ritual for even a small amount of time initially, and then gradually build it up to larger and larger intervals of time.
Okay. I have a question that's a lengthy one, so I'm going to paraphrase it a little bit. But
Okay.
the gist of the question is that the child's doctor is reluctant to indicate PS in his diagnosis. He feels that there may be ramifications for the child as an adult. And so the question is, what do you think of that? There's no complaint about the treatment. It's just that this idea of ramifications in the future with PS diagnosis.
See, thinking about this one. Physicians, we all have different approaches to handling diagnosis. So I believe that the physician probably has very good reason for not wanting to put the label on. And labeling children in general, the only reason I, in my professional opinion, like to put labels is if the label could help the child or the individual. So if there's something that the individual will be getting from that, I mean, putting a label on paper is different than actually giving the label verbally, but putting a label on paper, the only way I like to do that is to get the individual additional help, support, or services that they would need, and it would have to be documented on paper for. So, so I could, if the physician is still reluctant to put it on paper when there are benefits to, additional services that the child could be getting, then to me, that doesn't make so much sense. But I can understand not putting it down on paper if we want to, if there really isn't anything more that we could get for this child by doing that. So again, giving a label verbally is one thing to a family member, to to the child, and him or herself. But putting it on paper, we never know. With our insurance industry, with with things going on, I understand being cautious, but again, not being cautious to the point where we're withholding possible services or treatment options from a child. Okay.
Okay. I have a question that kind of has to do with the program at Rutgers.
Okay.
And it's around how the program works. So since the clinicians at Rutgers are graduate students, will they stay with my son, or will he move from one therapist to another? So you explain a little bit about how that works.
Yeah, that's a very good question, and a common concern amongst parents who do come to our clinic. Basically, the graduate students are here for 4 years. And I usually get students in their second year of graduate training, so second, third, and fourth year students. And typically, a kid who we think is going to be in treatment for a while, which is not our goal. Our goal is to keep children here for no longer than 6 months to a year. However, sometimes kids do need additional services, and they do go on for 2 to 3 years. So if there is a child that does come into the clinic who we have a feeling will need a longer amount of services, we will give them typically to a clinician that is, in their second year of training. And this way that the child could stay with the clinician for the second, third, and fourth year. And we've never had a child or adolescent stay with us longer than 3 years at this point. And of course, I've only been here 4 years, but typically we don't keep individuals in treatment that long. Sometimes they leave treatment and then come back to treatment, and at that point, maybe they would be transferred to a new clinician. But the good thing is that I'm here, and I supervise all the cases very closely. And so I do know each case. I do know each family member. I do sit on each intake that comes into the clinic. So I will always be the familiar face, and I will always know what's going on with the case. And that usually lends for some consistency if a clinician does need to be, a patient does need to be transferred. So, so again, the clinicians, they stay, they're trained in my program for 1 year to 2 years, but they do keep all their patients or clients for the time that they are here at Rutgers in their graduate program. Okay.
All right. I have a question about the Rutgers program, another one.
Mm-hmm.
Will the Rutgers program accept a child who has not made the DSM-4 criteria because it hasn't been a full year of tics?
We see individuals that have been diagnosed with chronic tic disorders. We just had a case today that came in with a chronic motor tic that we are treating, chronic motor tic and oppositional defiant disorder. So definitely, I mean, our criteria is anyone who suffers from a tic disorder, whether it be a transient tic disorder, and additional comorbid disorders, someone with chronic motor tics, chronic focal tics, and TS, and also a tic disorder not otherwise specified if you want to go with the DSM-4 criteria. So yes, as long as the individual has a history of tics, we will work with them in our clinic.
Okay. Lori, that pretty much wraps up our questions for tonight.
Okay.
So I'm going to turn the program back to Kelly.
Okay.
Thank you so much for joining our webinar on mental health treatment for individuals with Tourette syndrome. There is an exit survey which we would love to have you fill out as you exit from the webinar. Please fill out the evaluation. The chat board will be open tomorrow and available for the next 7 days on the NJCTS website for additional questions that weren't covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. This ends tonight's webinar. Thank you, Dr. Rockmore, for your excellent presentation, and thank you for everyone who